It's okay? All right. Thank you very much, Shabab, for coming back on time. So, we've got to start the lecture again where we left. We are talking about the flow of air inside and outside the systems. I think now you are somewhat familiar with the mechanics of breathing, that how system operates, how pressure change, and how air moves inside and outside. Okay? And the two pressures which were very, very important were the intrapleural pressure and the intra-alveolar pressure. Okay? We talked about the values also, if you remember. Okay? Intrapleural pressure is still a mystery. It's a very mysterious pressure, very interesting one. It keeps on changing during the phases of breathing. But normally, we know one thing about it. It always remains negative, whatever the phase of respiration is under normal conditions, breathing. Okay? I'm not saying in all conditions, I'm saying normally, like we are having inspiration and expiration. Okay? But if I am breathing against force, very forceful breathing, then this pressure during expiration can become positive. Okay, it crosses the zero value and it can go to positive. It is not -5 in all cases. -5, -7.5, -5, -7.5. That is the situation in our normal breathing, right? We are having right now. But or I'm coughing. In coughing, I develop a positive pressure because it's such a shadeed effort of my system that my pleural pressure becomes or like this when I'm doing it. What is happening? The pressure is becoming positive. So these are the physiological conditions in which your pressure can become positive. Also, if you are having a balloon and I give you, fill it very quickly and give it back to me. I give you a balloon and you say, you will do 3 or 4 times and you, Dr. Wajed, this is the balloon. When you are doing, what is happening to your pleural pressure? It's turning positive, okay? So it becomes positive value and it goes very high during your intense expiratory efforts. Shadeed efforts of your expiration will turn your pleural pressure into a positive pressure. So you got the example of pleural pressure changes. Pleural pressure is negative because one factor I gave you. What was that factor? Lymphatic pumping. But that is for the maintenance of the negativity. I did not give you the answer at that time that which mechanical force is mainly responsible for keeping the pressure negative inside. I told you these are the 2 layers of the pleura with a little fluid. If you press them like this, it's a positive pressure. No. What you are doing actually is you are trying to take this layer here and you are trying to take this layer here. It means you are acting in the opposite directions normally. How? This is a question. We did not understand that. What is the meaning of this one? See, again I'll tell you one thing. Lungs are attached to the visceral pleura. Do you remember that? Yes. And lungs are elastic tissue. They are elastic in nature. You know the property of elasticity. If you stretch something, it will try to come back. Okay? It will try to become smaller in size. This is the elasticity. Going back to its natural position. Lungs are inflated always. Okay? What is the normal position of the elasticity of the lung? Will it go in this direction or will it become smaller in size? Smaller. Becoming smaller. So if the lungs are trying to become smaller all the time because they have elastic force, are they trying to pull visceral pleura in this direction or in this direction? In this direction towards themselves. Alright? Now, think about the parietal pleura now. What is attached to the parietal pleura? Thoracic cage outside. The thoracic cage also, it is built in such a way that it also has elasticity. Okay? It is controlled by the muscles. Do you know that? Many muscles we talked about. Okay? But If you cut all the nerves of those muscles which are controlling your thoracic cage, normal thoracic cage, if you cut all the nerves, now there is no supply to the muscles, then your thoracic cage has a natural elastic tendency to go outside. Where will it go? Outside. And it will become like loose and outside. It will become bigger in size, your thoracic cage. So your natural tendency of the thoracic cage is in which direction? Outside. Your natural tendency of your lungs is in which direction? Inside. Now look at the poor pleura. Parietal pleura is associated with thoracic cage. Visceral pleura is associated with? So one is trying to go in which direction? Here. The other is trying to go in this direction. They cannot be separated. Why? Because a film of water is mawjood. So what kind of pressure will develop inside them? Because one is trying to go here, other is trying to go here naturally. So the pressure will become a negative pressure. So did you get the reason? Why do we have a negative pressure inside the pleural cavity? Okay? And this is the cause of the pressure. And how do you maintain the pressure? By keeping it the same? By lymphatic pumping. What if you block the lymphatics? What will happen? Fluid accumulation. And if the fluid accumulates, what will happen? Positive pressure. The pressure will become positive. Okay? That's why you have to remove the fluid. You throw the fluid away. Keep on throwing so that you maintain only a little fluid, and that's okay. You got the point? This is how pleural pressure works. What is the cause of the negative pressure and who maintains the negative pressure? You know the reasons now. Any confusion about that? Clear? Okay. Look at this picture. We are using few new terms for the pressures which are very important for understanding pathologies and the clinical medicine. This is airway. Trachea dividing into the branches. You can see that. Some air is present inside the trachea. Always. You know, dead space air is mawjood. Wherever this air is mawjood in some area, it will have some pressure. Isn't it? If air is mawjood in this room, I'll call, oh, it's a room pressure. I'll say, there is a room pressure mawjood here. If there is a pipe and air is mawjood in that pipe, I'll say, okay, a pipe pressure is mawjood inside the pipe. Some pressure is mawjood. Okay? So this pressure inside is known as the airway pressure. What do you call it? Airway, because it's airway. Outside you have the pleural cavity, okay? Here you have the pleural cavity mawjood. So on one side outside you have the pleural pressure mawjood. On inside you have the airway pressure. There is a difference between two pressures. We calculate the difference, and this pressure difference is called trans airway pressure, which is mawjood across the wall. The pressure which is working across the wall is called trans airway pressure. Okay? This trans airway pressure is trying to compress or trying to pressurize the airway to collapse it. But airway doesn't collapse because some air is always mawjood. It's not. But this trans airway pressure changes in different conditions and in different diseases. If the trans airway pressure becomes high, more, so the outside pressure becomes more. So what will happen? More compression. And if it is coming on the alveoli also, what will happen to the alveoli? They can collapse. There is a chance of collapse. So whenever the trans airway pressure tries to increase in any condition, external pressure is coming on the airways. Now you cannot collapse the airways very easily because they have cartilages or they are made up of smooth muscles. But if you are working around the alveoli, they are soft structures, isn't it? They can be collapsed. So remember, trans airway pressure is a compressing pressure from outside. Am I clear? Okay. Because this is a new term which we did not use that before. Now we are using another term. Look at the two pressures. What is this structure? Alveolus. What is the pressure mawjood inside the alveolus? You know that? Intra-alveolar pressure. What is that space between the parietal and visceral pleura? What pressure is mawjood there? Now you see the relation between these two pressures, intra-alveolar pressure and intrapleural pressure. We did before also that as intrapleural pressure changes, it also changes the intra-alveolar pressure. Alright? The difference between these two pressures is called transpulmonary pressure. What do you call it? Transpulmonary pressure. Okay? And transpulmonary pressure is a very, very important pressure which measures the expansion of the lungs, how the lungs will expand. If the transpulmonary pressure increases, then there is expansion of the lungs. And if this pressure decreases, then the lungs are not expanding, they are going back. Okay? So increase in the transpulmonary pressure is expanding the lungs. How do you calculate this pressure? The difference between your alveolar and the intrapleural pressure, that will give you transpulmonary pressure. Okay? More transpulmonary pressure, more expansion of the lung. Less transpulmonary pressure, less expansion of the lungs. Okay? Trans-airway pressure is a different pressure. That is pressure between airway and outside, yani pleural pressure. And if that pressure increases, then there is compression or trying to narrow down the airways from outside. Okay? I'll show you one more picture, and that's important. Look at this one, please. Now, this is a very interesting picture taken from Guyton, our book. But it is telling you something here. You can see different graphs or the curves. The first one is the volume change, the red color line. Can you see the volume line? Okay, changes in the volume. But before that, whenever you start reading any graph, first of all try to see the structure of the graph, what is given in the graph before doing the curves. First of all, see, two axes are given, the vertical and the horizontal. Here you are taking the volume, okay, volume change in the lungs, 0.25 or 0.5 change in the lungs. It is liters, 0 liter to 0.5, okay. Here you are giving pressure. In this area you are talking about the pressure curve. Okay. So from 0 you are going in minus direction, and from 0 you are going in plus direction. You can see also here. Okay. And here you are having the time. This phase is inspiration and this phase is expiration. Again you will have inspiration, again you will have expiration, and this will go like this. One inspiration and one expiration is shown in the graph. This is one respiratory cycle. So on this line below, you are talking about inspiratory and expiratory phases and a time. And on this line, vertical line, you have got two parameters. Pressure is given and volume is given. So now we understand the graph more easily. Okay. When you are running in this direction, you are running in time direction. When you are running in this direction, you are running in either pressure direction or you are running in the volume direction. Is that clear? If you are coming down in the graph like this, you are dropping in terms of pressure or you are dropping in terms of volume. It depends really. Okay? Look at this graph. I talked to you that when we see the graph, we'll talk about inspiration. Which one is longer and which one is shorter? Are they equal in size, first of all? No. There is a little difference you can watch, isn't it? Yes. Can you observe? Which one is shorter? If I have 5 seconds of total respiratory cycle, khamsa, 5 seconds, how many seconds would you like to keep for expiration and how many seconds for inspiration? 2 and 3. Make it 2 and 3. Okay? So 2 seconds for inspiration and 3 seconds. Why? Passive. Okay? See, active process, muscles work quickly and they take shorter time. But relaxation of the muscles take a little tawil time. So expiration is a little longer and inspiration is a little shorter. 2 seconds, 3 seconds, 2 seconds, 3 seconds. Like this it works. Okay? Am I clear? Okay. So that's why you see this one. Now you see, very quickly please. You are starting from inspiration. A new cycle is starting. You are working, this pressure line is your pleural pressure line. This pressure line is your alveolar pressure line, and this is your volume graph. When you are starting from inspiration, what was at the badaya? What was the pressure? 5. Is it 5? Yeah, it is -5 you are saying. Okay, isn't it? It's -5 here taqriban, isn't it? You are starting. From -5, it should go to what? minus 7.5. So it drops to a value takriban here in the middle part, or in this part it becomes how much takriban? Minus 7.5. all right, and it goes like this, it remains minus 7.5. It will never become 0. I'm talking about pleural pressure, okay? I said pleural pressure is always negative. So it remains minus 7.5. Now in expiration, okay, it from minus 7.5 it will go back to which value? And this is again the minus 5 value. So it's a run between minus 7.5 and minus 5. Yeah. What does you want? Okay, no problem, go. Alright, so our idea is to see the negative changes in the intrapleural pressure, less negative and more negative, less negative, more negative, expiration, inspiration, expiration, inspiration, alright? This was the first one, becoming less negative again, here more negative you are turning. Is this line clear? The pleural pressure, this one, look at this one. You are starting here, at the beginning of inspiration, it's 0, it's صفر. Here the value is 0. During inspiration, somewhere in the middle of inspiration, it becomes how much? 1. Okay, but at the end of inspiration, again it becomes 0 takriban, isn't it? And during expiration, it becomes plus 1. But at the end of expiration, it will become. So these changes, this is what we discussed actually. Okay? Alright. The difference between the alveolar pressure and the pleural pressure is called transpulmonary pressure. So this is the transpulmonary pressure in different parts. Okay? Where do you see the transpulmonary pressure, in which part really is more? In which part? In inspiration it becomes maximum really, isn't it? Somewhere maximum you will have this achievement here, it's maximum. It means during inspiration there is maximum expansion of the lung. I told you this shows you the expansion of the lung, okay? And what happens to the transpulmonary pressure at the end of the expiration? This is the size of your transpulmonary pressure, isn't it? It is decreased, and you will see it maximum here in this region, isn't it? So this transpulmonary pressure is changing because it depends on these two things. So its result simply is not the same, it keeps on changing. Okay? Inspiration, expiration. But whenever you increase the transpulmonary pressure, a difference between alveolar and pleural pressure, your lungs will become more and more expanded. Okay? We'll talk about that transpulmonary pressure in expansion of the lungs in the coming slides. But did you get the meaning of transpulmonary pressure? Yes. Pleural pressure, alveolar pressure. Look at the volume here now. When you have the transpulmonary pressure maximum here, what happens to the volume of the lungs? Maximum. When you have the minimum value of the transpulmonary pressure here, what is the volume of the lungs? Minimum. Okay, so it means the volume depends on the changes in the pressure. If you are changing the transpulmonary pressure, you are changing the volume of the lung. Increasing the transpulmonary pressure, increase volume. Decreasing the transpulmonary pressure, decrease volume of the lungs or expansion of the lungs. Alright? When you are decreasing, this is decreased transpulmonary pressure. This is increased transpulmonary pressure. Look at the volume here, look at the volume here. Relate the volume with the pressure. You can easily find it out. Am I clear about that? Okay. Alright. Yeah, please. This one. Yeah. You're saying not here?
Yes.
Alright. Actually this is the area, the middle area will have the maximum one really, okay? So the end point of your inspiration and just the beginning of your expiration, that part actually is the area where you have the transpulmonary pressure best value. This area is your best area from this point to this point really, okay? Here, this is the transpulmonary pressure where it is maximum. The difference becomes maximum, and here you have achieved the maximum value. Okay. After that, it will start decreasing, and slowly, if you check, slightly it is decreasing. It's coming slowly. It's not changing very much, but slowly and slowly it will decrease and it will go to the expiration end. All right? Okay? So, but this is the area where you have the maximum volume, and shift the volume remains maximum for some time here. Not at the beginning of expiration it is coming down like this. It is still somewhat maintained because of the elastic properties of the lungs. It remains for some time and then it starts decreasing slowly. Okay? All right. Look at this picture. Are you familiar with the picture? Inspiration up 0, inside -1, pleura -7.5. Okay? The values. This is all we have done already. Okay? I'm not reading all this stuff. Look at the expirations, please. Value very quickly. -5 in the pleura, +1 in the alveoli, and 0 is in the atmosphere. So the direction is up now. It will be moving like this. All of you? Okay? Great. I'm not reading all that. Okay? You will do it yourself. Lungs have two very special properties, Shabab. Now be careful. We are coming to a very, very interesting and important part, and we'll do the clinical applications also. Elastic tissue we know about. Lungs have an extensive elastic structure. And elastic means whenever you pull it, it will try to go back really. Okay? It has some recoil. Recoil means going back. So it's a natural tendency. Whenever you stretch the elastic, it tends to go back, and it develops a recoil pressure inside. When you stretch it, the recoil pressure develops, and the recoil pressure is trying to get the elastic back to its normal position, isn't it? Lungs are also elastic, so lungs will have a recoil pressure also. Okay, the tendency of the recoil. Recoil means to come back. You have a spring, okay, like this. You have seen the spring. Okay, when you stretch the spring, tension develops in the spring, but as you leave the spring, it will try to come back, or it will show a recoil again coming back, isn't it? Another very important property of the lung is surface tension موجود in the alveoli. Please look at this now. This is an alveolus, a sketch of an alveolus. And inside the alveolus, some small molecules are shown in. Can you see in the picture? Okay. Now the question is that what are these molecules? Water. Okay. All right. The concept is that inside the alveoli, first of all, do you think alveoli are dry structures from inside? If this is an alveolus, and let's not talk about surfactant right now. If surfactant is not موجود in the alveoli, surfactant is a zeth, it's an oil, okay? But I'm not talking about surfactant, I'm talking about alveolus without surfactant. Do you think it will be dry from inside? Because air is موجود inside, air is continuously موجود here. So what do you think about the walls of the alveoli? Okay, the walls. Are they dry or they are wet? Or we have to choose one answer from wet. They have some wetness. They are not dry completely. Why are they wet?
Because the water.
Where does that water come from? If you rub the wall of the alveolus, where surfactant is not موجود, okay, the wall of the alveolus, if you rub, you'll say a very fine film of water, very thin, very fine layer of water is موجود. Not much water, only a fine layer of water is موجود. Why and where from?
To protect the alveoli from being exploded when there's dust or something in. Is that protecting layer?
Okay, it is naturally present. I'm asking about the source. Is it coming from outside? Is it coming from the cells which are making the epithelium? Shuf, look at these cells, these tiles here, okay? Do you see the tiles here on the floor? Each tile is a cell, for example, and you are making the epithelium. This is epithelium. All these cells are موجود here. The cells are joining together to make the epithelium completely, okay? In the alveoli, there are two types of cells. You have done it in histology also. Type 1 cells and type 2 cells. Type 1 cells more in number, and they are regular cells. Type 2 cells, a dark type of cells, here and there they are modules. Okay, type 2. Type 1 are for the exchange of the gas, basically, the gas exchange. Type 2 cells will give you some special oil which is surfactant. Okay. Type 1 cells, and maybe type 2 cells also, they are continuously giving some water from inside. They have water. Okay. So a little water is being diffused from there, and this water is modued all over the inside surface of the alveoli. Okay. If water is modued and air is present in the alveolus all the time, this is a very dangerous situation. Why, Kebab?
Tension of the wall.
Yeah, remember there is a physical property of the water. If water layer is modued anywhere, and if air, Hawa is modued there, well, because of that air and water contact, the water molecules are attracted to each other. Water molecules will be attracted. When air comes in contact with the water, the surface molecules of the water, the surface, they tend to attract each other, and the surface comes to contract. So if air is modued naturally, and layer of water is also there, and if you allow their interaction, what will happen to the water? It will try to contract. If it tries to contract, it is favoring the collapse of the alveolus. Okay, so there is a chance of alveolar collapse if only water is modued. Now this is a dangerous situation. You don't want alveoli to collapse. If the alveoli collapse, you cannot breathe, you cannot have gas exchange, isn't it? So you should do something. Now you do something. You take an oil like surfactant, okay, and you take an oil, and this is the water layer, this is the water layer everywhere. So you brush oil like everywhere, here, there, everywhere. You just paint oil over the water, or you mix oil in the water. Once you mix oil in the water, surfactant in the water, what will happen? Now your air cannot do anything bad, okay? Because now air is not contact with the water. Water is mixed actually now, okay? But if only faqat water is modued, alveoli will like this, the balloon is becoming smaller in size, okay? So now you know the function of surfactant. What is surfactant doing? This phenomenon of tension, developing tension in the water, is called surface tension. So alveoli have surface tension. Why? Because water is modued in them. But alhamdulillah, we have an agent which opposes the surface tension, and that agent is known as surfactant, anti-surface tension, which is opposing the surface tension. So is surface tension good for the alveoli or bad for the alveoli? Okay, and surfactant, is it good for the alveolus or the bad? Right, definitely. So that is very important. Okay. Remember one thing. As the size of the alveolus is increasing in inspiration, the size is increasing. Okay. What will happen to the surfactant layer? Surfactant is the oil molecules modules. If you are making the size of the this alveolus big, okay, what will happen to the layer of surfactant? Becoming thin or thick? Thin. And if you are making the size of the alveolar space small, what will happen to the thick? So when you are having small alveolus, your surfactant film becomes thick, and when you are expanding the alveolus, your surfactant becomes thin. Okay. Surfactant is more powerful when it is thick, isn't it? And as you become thin and thin in surfactant, what will happen? It becomes weaker and weaker. So if you are increasing the size of the alveolus, what is happening to the surfactant? Weak or strong? Weak. What will happen to the surface tension? Increase. So that's why as the size increases, the surface tension increases and the surfactant action decreases, so that you stop the alveolus size, and now you will have expiration. In expiration, what you are doing? You are increasing the surfactant concentration, okay, and you are decreasing the surface tension. So the size of the alveolus becomes smaller and smaller. But as the size is becoming smaller, there is khatar. What is the khatar? Collapse. But who will prevent the collapse of the alveolus? Yes. So this mechanism goes on. So surfactant becomes strong when the alveolus is small. Surfactant becomes weak when the alveolus is bigger in size. So both ways the story is going like this all the time. Okay? You will read it yourself. What is surfactant? Where is it coming from? What is the chemical nature? It is so easy. Okay, it's written here in the book also. I'm not discussing it. I'm looking for some functions, very important. One function, the surfactant. Quickly go over the functions. This is physiology, this is application. Surfactant, please. Anti-surface tension. So it prevents the collapse of the lung. First, most important function. Those children who are born with deficiency of surfactant, what is the problem? It's the respiratory distress syndrome, infant respiratory distress syndrome at the time of Vilada. Some premature babies are born with little surfactant mawjood in the lungs. If it is not mawjood completely, those areas of the lungs will collapse or they will not open. And the baby has to, little baby has to gasp really in order to open the lungs because lot of resistance is mawjood if surfactant is not there. So surfactant is helping you to expand your lungs easily, isn't it? So deficiency of surfactant will lead to collapse of the lungs. If I develop a disease, now I'm an adult person, and if I develop some disease and my surfactant decreases, then there is a chance that some areas of my lungs can collapse. So it can happen from the time of Vilada, from the newborn, or it can happen in like this. Excess of cigarette smoking has a chance to decrease the secretion of surfactant. I'm not saying that the lungs will collapse, but there is a chance here and there of few alveoli collapsing, and overall function of the lung is slightly reduced. This is one of the disadvantages of smoking. Okay? All right. So if you have good amount of surfactant mawjood in your system, will your lungs expand easily or with difficulty? And if your surfactant is less, will you have more resistance in your system or less resistance in your system? So your work of breathing, your work of tanaffus will increase with surfactant or decrease with surfactant? Look at my statement now. Your work of, your total work you are doing some work for your tanaffus, isn't it? Your tanaffus or breathing work, is it decreased with the surfactant or it is increased with the surfactant? Decreased, all right? So it is good that with less work you are doing the function, isn't it? So we need the surfactant all the time. If surfactant is not mawjood, we'll have to do more work for the breathing actually, and our breathing becomes heavy. Okay? Yeah, the rate increases and effort, your muscles will be active all the time and the muscles will be exhausted. Okay? So did you get the concept of surfactant? What is surfactant doing for you? One more fascinating function of the surfactant which you will remember. Surfactant is causing the opening of the alveoli. Can I say that? It keeps the alveoli open. Okay? It prevents the collapse. Am I right? Okay. I'll show you one slide. Look at the slide and see. Alveoli are attached like this. Alveoli are not separate balls. Their walls are partially attached with each other. So they are dependent on each other. Isn't it? Okay? So, one good point about this situation, please. Look at this one. This is not the function of surfactant, but this is one phenomenon happening in the alveolus because alveoli are attached to each other. And let's suppose one alveolus becomes kharban. It has less surfactant or it is collapsing in nature. If it is collapsing in nature, it collapses. What will happen to the other alveoli? Will they also collapse along with that? No. It will try to stretch the walls. Okay? So, these are attached here. If it tries to collapse, will these alveoli easily allow this one to collapse or to go back? Because the central one is supported by the side ones also. The central one is bad. It is trying to become small, but it cannot easily become small in size because it is connected to the surrounding. This is called interdependence. Okay? If I'm holding him and I'm holding him and he's trying to go there, so if I'm here, he cannot go easily there, okay? But if I leave him, he can go anywhere, isn't it? So if interdependence is there, then the alveoli don't collapse easily, okay? They have a problem, but they don't collapse. So even if the size becomes smaller, these alveoli will try to have the elastic force and they will try to bring it back or at least maintain it, not collapsing, not allowing it to collapse. Okay? Do you see that? This phenomenon is known as interdependence of the alveoli over each other. Okay? One more thing. If surfactant is not maujood, okay? If surfactant is not maujood, what should happen to alveolus in that case? It has a tendency to collapse. If in some area the alveoli collapse, okay? Alveoli are supported by, I don't know if you have seen the diagram in anatomy or not, that they're supported by capillaries from outside. It's like capillaries, it's a basket of capillaries holding them. And a full alveolus with air, it is partially compressing the capillaries also, and it is pressing the capillaries also. If this alveolus collapses, what will happen to these capillaries? What will happen to the blood flow in these capillaries? Increase. If the increased blood flow is there, what will happen to the size of the capillaries? What will happen to the wall of the capillaries? Stretching or less stretching? Stretching. If the stretching is there, what is the chance? Edema. So the fluid can come out of the capillaries. Yani your alveoli are supporting the capillaries also. And alveolus is controlled by the surfactant. If you don't have the surfactant, the alveolus is gone. If it is gone, the capillaries are now free. They are dilated. More blood is flowing. They are stretching. And mumkin, there is a chance, imkan is always there, that edema can develop. So if surfactant is not maujood in the lungs, another chance, another danger is the development of edema. It can also happen. Did you see the functions of surfactant? Okay, it's keeping the alveolus open for the normal tanaffus, and it is also preventing the edema. All right? Okay. Effect of sympathetic and parasympathetic, very quickly in 2 words only. I'm not staying here for a longer time for this slide. Very simple. Your tanaffus system, is it supplied by autonomic nervous system? You know that very well. Okay. Sympathetic and parasympathetic. Sympathetics and parasympathetics are supplying the smooth muscles and the glands of the mucous membrane. Okay. What is the effect of sympathetic on the smooth muscles? Dilation. So your airways will become a little dilated, okay, and the size will increase. What is the effect of parasympathetic stimulation? Now I'm talking about the resistance in the airway. When you are having sympathetic stimulation, what should happen to airway resistance? Decrease. And if you are having parasympathetic stimulation, it is increased. Okay. In asthma, in Rabu, what happens? Resistance is increased or decreased? It is increased, isn't it? Okay, because your passageways become narrow due to many reasons. One reason is constriction of the bronchi and bronchioles, smooth muscles. Other is some mucus is maujood, okay, and some of the extra pressure from outside is there, which is trying to collapse the small airways. So all the factors are causing the compression and narrow passage, so your resistance will increase in that case. That's why you give bronchodilator drugs, sympathetic drugs in asthma, isn't it? They open and they increase the size of the airways. Alright? So airway resistance is a very important factor in some diseases. Especially on top of the list we have bronchial asthma. Okay? In some obstructive disorders also, like emphysema and chronic bronchitis. Emphysema and chronic bronchitis, Shabab. Are you familiar with the word chronic bronchitis? Emphysema, you know, you told me in the morning. Chronic bronchitis is the inflammation, chronic, tawil al-mudda, it's like going for a long time. This is chronic bronchitis. This also causes obstruction inside the passageways, small bronchioles and the bronchi. So emphysema and chronic bronchitis together, they are chronic obstructive pulmonary disease, COPD. When I say the word COPD, I'm talking about 2 diseases together. One, chronic obstructive pulmonary disease. I mean to say 2 diseases. It includes emphysema and chronic bronchitis. In some patients, you will have more emphysema and little chronic bronchitis. In some patients, you have more chronic bronchitis and a little emphysema. In some patients, you have nus chronic bronchitis and nus emphysema. It's a mixture. You can have different patients like this in COPD. Some may have more emphysema, some may have more chronic bronchitis. Okay? All right. This is another very important, please, slide. Look at this one, Shabab. Airway compression. This is your airway. This is your alveolus, and then this is showing you a bronchiole like this. Okay? You have a pressure موجود across. Some pressure is موجود inside. You call it airway pressure. Some pressure is موجود outside. And yeah, that is pleural pressure. The difference between the two pressures is trans airway pressure. And trans airway pressure, I told you, is a compressing pressure, isn't it? It tends to compress. If you increase the this airway pressure, there's a chance of alveolar compression and collapse, and the chance of compression of your bronchioles also. So the air will have difficulty in movement. Okay? Now, look at this one. Look, normal physiological conditions. Okay? When you are breathing, having expiration, forceful expiration, okay? What is happening? Your trans airway pressure is increasing. Okay? Definitely, it will increase. So it will try to compress your airways. Okay? If the trans airway pressure is increasing, your airways, smaller airways, are compressed from outside. If your airways are compressed from outside, what will happen to the air movement inside the bronchioles? More resistance or less resistance? If you are having compression from outside and your air is trying to move out like this during expiration, okay, resistance will increase. Sir? Okay? You are compressing from outside, your pressure is more. If you are compressing from outside, okay, and what will happen to your pressure in the lower part here, okay, if increased, because if you are compressing the tube from here, I am showing you, if you compress the tube from here, what will happen to the pressure in this area? Increased. Okay? Here the pressure is less, here the pressure will increase. You are slightly compressing it from outside, so a pressure difference is developed. High pressure here and slightly less pressure here. If there is a pressure difference, what will happen to the movement of the air? Will it move or not? So, yeah, it will move. Even though you are compressing it from outside, but still you have a difference of pressure, high pressure and low pressure. So still your expiration will go on. Yeah, it will be difficult. So in expiration, it's a little difficult to expire. But alhamdulillah, expiration continues. Why continues? Because here you will develop higher pressure and here you have a little lesser pressure. This pressure difference will cause the movement of the air, and the air will still move. And if the air is moving inside, this moving air will try to open and will try to make its way. Okay? It is going inside and it is trying to make its way and it will go. Okay? So alhamdulillah, there is no problem in expiration also in normal persons. In inspiration, there is no problem at all. Trans airway pressure is very little and their airways are open. And see, in inspiration, you are taking air from inside. When your air is moving inside, this air is trying to make its way and it's trying to open the airway itself, isn't it? So one movement of the air is opening the airway. Number two, your trans airway pressure is little. So it will not compress from outside. Alhamdulillah, no problem in inspiration. In expiration, your trans airway pressure is more. But even this will cause some help. If it is compressing, it will develop a pressure difference. That pressure difference is the main force which will move the air up. Okay? So normal persons have no problem in inspiration or in expiration, whether it is forceful or a normal, okay, because of this issue. But Shabab, if you have an